Eros, as always. Excellent. All right. Wow. A lot more people. Great. Fantastic. So, hi, everyone. Welcome to the Journal Club for the month of March. Pedro Ramirez, Editor-in-Chief of the International Journal. Today, along with all of my visitors from around the globe, it is extremely great opportunity to always reach our March special issue. And we have had such an amazing collaboration with leaders within our field for this special issue. Joining us from those guest editors is Dr. Christina Fotopoulou, and some of the other guest editors could not be here because they're either in conferences or in the operating room. We had also Gerda Eriksson, Glauco Baicchi, and Oliver Zivanovic, who served as guest editors for the special issue. So certainly want to welcome everyone for taking the time. And particularly, I know for many of you, it is actually Friday evening. So what a way to spend Friday evening than talking about gynecologic oncology. So I truly appreciate your all being here. And Christina, thank you, and welcome to the Journal Club.
Thank you for having me. Thank you for the collaboration. It was a great, I think at the end it's an excellent special edition where we have brought a lot of new knowledge in one journal. So it's great.
Well, thank you so much. I know that it was a lot of time and a lot of emails to get this special issue completed, but we're really so very proud. And again, of course, for the March special issue, we typically don't follow the standard format, so we'll have more of a conversation as to what do you see the value of this particular issue is to the gynecologic oncology community, and why specifically this topic around surgery in gynecologic oncology for this special issue.
So I think there has been a lot of discussion about the value of surgery in the era of such an amazing revolution in the systemic treatment. So we have now in many cancers novel approaches with targeted agents that we didn't have in the past, where we just see the tumor melting away practically. So the question is how surgery is being placed into that framework, and whether surgery is still important and how important it is, and also the timing of surgery within all the systemic approaches. So we try to put to emphasize and to also redefine the value of surgery within these new developments in the systemic and radiotherapy treatment. But also we as surgeons and gynecology surgical community have done many new advances in terms of not just surgical resection, but also reconstruction. So we can go far more further than we used to be able to do in the past, with lower morbidity and better quality of life, just because we can reconstruct things we wouldn't perhaps do in the past. So we have put all this together in one special edition. Plus, we have also addressed rare tumors like sarcomas, like trophoblastic disease, which is, of course, always a dilemma for all of us. Even for large specialist centers, we always need to look up how to treat them. So we have tried to bring it all together in one special edition just for you.
Fantastic. Well, thank you so much, and for that introduction. So Christina, if you don't mind, I'd like to start asking specifically about some of the topics that were covered in the special issue, and I'll talk about an area that I know that is near and dear to you: ovarian cancer and ovarian cancer surgery. I know you love neoadjuvant chemotherapy. But one of the things that was brought up is this really great article by Ryan Kahn, who used to be one of our fellows, and Dennis Chi as well, on extra abdominal cytoreductive techniques in ovarian cancer. And it's called How Far Should We Go? And I think, obviously the question is that as we see that there's an increase in neoadjuvant chemotherapy use, as we see that oftentimes, the candidates for surgery are changing in a way. Do you really feel there is a role for extra abdominal cytoreductive surgery.
Yeah.
As many would just say, isn't it safer and easier to just give neoadjuvant chemotherapy? What are your thoughts? And please try to be unbiased.
Yeah, no. I will be unbiased, especially in view of the fact that I was just reviewing my trust patients yesterday. How many of them are still alive in the primary and in the interval arm? So
Oh, so we'll stop there right now. What is
exactly.
the show?
Exactly.
Can you just tell us what the trust trial is going to show, since you were
Yeah,
on
I will
the
tell
topic?
you now. I will tell you now. So I hope we can give you the results in the end, by the end of this year, maximum the end of next year, but it will soon come. So the only thing I can tell you is that many of the trust patients, even though we now are following them up since 5 years, are still alive, which is it's actually a sign of how important surgery is, that independently of the timing. Yeah, so good surgery is important no matter of the time. You can have good surgery up front, but also good surgery at interval, and bad surgery up front and bad surgery at interval. So one shouldn't mix bad surgery with the timing. So I think, Pedro, what you have just said is very, very important about the extra-abdominal side reduction. So with the very advanced imaging techniques that we have currently, and I'm sure all of you have, and most of our patients now come not just with a conventional CT to us, but with a PET-CT and diffusion weight MR. It's actually very difficult not to find somebody with extra-abdominal disease. I mean, almost all my patients will have a bit of axillary lymph node, a bit of a paracardiac lymph node. There is always something somewhere. And the question is not how far we can go and whether we can resect it. The question is whether we should. Because in ovarian cancer, we shouldn't chase ghosts. And we know that even though we remove macroscopic, or we should remove macroscopic disease, microscopically, our patients are full of disease. And that's why they need chemo, that's why they need PAPs. So to go and chase 8 millimeter or 5 millimeter axillary nodes, it's completely illusionary, and also probably has absolutely no value. And I think we need to be careful between doing resections for the sake of resections and of sports surgery and doing really something good for the patient. Yeah. So the article of Ryan and Dennis really addressed that and really showed that it's not just about the sports of resection, it's just when it should be done. They clearly show it's safe to be done. Yes, it's fine, it's safe. We have the instruments. The patients don't experience massive morbidity. Why would they if done in a specialist team? But they also very clearly address the value and the rationale of whether it should be done, and what the survival benefit is. Yeah. So the answer is we shouldn't just remove whatever we see just because it's resectable. We should have in mind the tumor biology, the response of the patient, the profile of this patient, and not everything that is resectable. You know, it's a completely different discussion.
Yeah, no, really great, great perspective, and I appreciate obviously the soundness and the fairness of your answer in that. I also want to encourage everyone who is joining us. If you have any questions, please proceed to ask questions related to these topics. Now, Christina, before we leave the topic of ovarian cancer surgery. Another great article about bowel surgery in the setting of cytoreductive procedures. I know you have extensive experience in GI surgery and being able to perform bowel resection, small bowel, large bowel, with an increasing number of patients undergoing neoadjuvant chemotherapy. Those bowel resections likely are going to be less and less. And the question is, what are your thoughts on, who should be doing the bowel resection if our trainees now are not getting as many bowel resections because, patients are typically being operated at interval? What should be the number of bowel resections that a gynecologic oncologist should do per year in order to say, I'm the one that should be doing this rather than a gastrointestinal surgeon?
Yeah, that's a very good question. So, a very good topic. So, even though at neoadjuvant chemotherapy, we know that the rate of GI resection is lower, still, through the advanced technology and also through the neoadjuvant and application of neoadjuvant chemotherapy, we operate now more patients than we used to do in the past who would be impossible to be operated up front because they were too unfit or they were too extensive disease. So in total, we probably operate now more patients and we bring now more patients to the operating room than we used to do before. Also, we now have learned that it is possible to operate more elderly and more fragile patients just because we have learned the concept of prehabilitation, rehabilitation. So in total, we now operate and treat surgically more patients than we used to do in the past. So even though the number of bowel resections per percentage is lower, the absolute number is not necessarily lower. Plus, we now, through the desktop study, have increasingly more surgery at relapse disease, which we know it, and around 30-35% they will need a bowel resection. So we now have increased number of resections in the relapse setting. And also because our patients, through the PARPs, through all these targeted agents, they live longer and they relapse more. And also they, at some point, you know that even in the palliative situation, by doing a stoma, you can then make them possible to get, for example, I don't know, an AKT inhibitor to get again platinum sensitive. We have more patients to operate. And of course, the last point is that we now clearly, after decades, have finally understood the importance of centralization of care. So it's not just anybody operating one ovarian cancer per year, but all these increasingly more countries now introduce the concept of centralization. So all these ovarian cancers will now be centralized in big centers. So I have absolutely no worry about low number of exposure for our trainees for bowel resection, like zero.
Very well. So to our fellows, any questions you would want to bring up to Professor Christina Fotopoulou regarding ovarian cancer surgery, indications, approaches? Elena, I'm going to put you on the spot. You're right next to Christina Fotopoulou. So
yes, actually, I might ask something. You've been talking about upfront surgery, but I would like to ask something about the progression of disease and the recurrence setting. So I would like to ask you, in the era of immunotherapy, how would you treat oligoprogression? How would you recommend to offer surgery in the setting of oligoprogression? And how would you then offer immunotherapy and mix the treatment of those patients in the recurrent setting and in the PARP era and in the bevacizumab era?
Yeah, that's a very good question.
For on the spot.
Yeah, so the concept of oligometastatic disease is now very much in fashion. Everybody talks about oligometastatic disease. And it's so much into our daily life that all new guidelines now really have big chapters addressing only that. So we now have just issued, I don't know if you have seen the ESCO-ESMO consensus statement on ovarian cancer guidelines in islands of surgery. We now update the endometrial cancer guidelines, and all of them have separate dedicated chapters for oligometastatic disease. So oligometastatic disease is per definition a focus or lesions less than 4 or 5 lesions, depending on how you define it. And there are no other rules that actually would apply. Then, for example, in the relapse setting, surgery is important only if you are able to operate them tumor-free. So even if you have oligometastatic disease, but let's say it's in both lungs and you can't take them out because then the surgery wouldn't apply, whereas it would still apply if you can operate them tumor-free. But we have seen that, especially in the era of PARPs, there are women who will respond to PARPs and then progress only on 1 or 2 lesions. That's something that we didn't really used to see in the past so much. So we have now introduced the concept of just interrupting the PARPs for a bit, going in, removing or irradiating or somehow ablating this couple of lesions that progress, and then continue with PARPs instead of giving chemotherapy. So we now are going into this oligometastatic field more further away from really cytotoxic chemotherapy in the conventional way. And we try to treat the patients with a combination of surgical ablation, radiotherapy ablation, and immunotherapy, and going away from cytotoxic regimens.
Thank you very
Excellent.
much.
Thank you so much, Christina. And I wanted to touch on the subject of imaging and preoperative evaluation. And there's a really great article on imaging modalities, particularly for your ovarian cancer patients. Are you routinely doing CT scans alone, or are you doing PET CTs in determining which patient goes to surgery versus neoadjuvant chemotherapy?
So in ovarian cancer, the limits of operability are not really a big lung met. You can see that in the conventional CT. The problem in ovarian cancer that limits operability is this small nodule peritoneal carcinosis on the small bowel, or on the stomach. So we know that PET CT in low volume carcinosis largely fails. I mean, I've had many PET CT negative patients that I opened closed, and I'm sure many of you. That's why we have issued a couple of years ago the ISOC IOTA guidelines and consensus statement for the value of what imaging determines what. And yet PET CT is important if, for example, you have chest disease and you don't know whether it's cancer or not cancer. But in terms of defining surgical operability on the peritoneal carcinosis, PET CT doesn't have any benefit. Plus, you shouldn't forget that all these studies that we have that prove the efficacy and value of complete resection in ovarian cancer is macroscopic and in studies without any PET CT. For example, in the desktop study, in the LION study, the LION we didn't even do any CT. Desktop, hardly anybody has PET CT. Again, we shouldn't have the illusion that our ovarian cancer patients, no matter how well we operate on them, will be microscopically tumor-free. They won't. It's about what we see. So if in the CT you don't see anything big, then that's enough for me.
Okay. Christina, it's a question from the audience by Omnia Mohammed. And she's asking, I believe that in patients with platinum refractory or platinum resistant disease who have received chemotherapy and then respond to that chemotherapy, would those patients be candidate for cytoreductive surgery? So I guess it's the question is patients who have had refractory or recurrent disease that are responding to your second-line treatments, and would you consider surgery in that setting?
Sorry, so they were platinum refractory at first line, and then you give somehow Taxol weekly and they respond to Taxol weekly?
No, and Omnia, if you want to ask yourself, please feel free. But on the chat, I see it as patients who had recurrence, platinum refractory, who were treated with chemotherapy, and then
new chemotherapy, and then okay,
and then they respond. Are they candidates for cytoreductive surgery?
Yeah, good, but then they respond. How long they respond? I mean, the patients who are platinum refractory, if you give them a non-platinum monotherapy, because that is what is indicated, no, there is no evidence for value of surgery in those patients unless for palliation.
Yeah,
very clear.
I agree. We typically would not operate on those patients, nor on patients. I think there's a follow-up to the question. Patients with liver mets or lung mets, definitely, we would not operate on those.
Absolutely not. Refractory, so biology of the disease cannot be defeated by surgery, no.
Exactly. Okay, great. So I know that you might not have covered some of these other articles, and some of your guest editors might have, but obviously a very timely topic, the de-escalation of surgical radicality in the management of patients with early cervical cancer. We recently saw the publication of the SHAPE trial. Wonder if you have any comments that you would want to discuss on that topic.
Absolutely. I mean, I think we should all direct our radicality and to those patients who will benefit, so that we have time and resources and money to do it really for those who will benefit, and not to just, have an arbitrary radicality for everybody, for every indication. So I think the fact that we are brave enough now to do surgical studies like the SHAPE, like the desktop, like the Lion, like the Trust, it's a massive advantage that we didn't have in the past. I mean, in the past, studies and prospective randomized studies were mainly for chemotherapy, immunotherapy, and not for surgery. And now we as surgeons really have understood that concept and are brave enough to do that concept. So it's great. There is also no discussion that in some, I mean, look at the example of breast cancer, where we used to think that by removing the whole pectoralis muscle, the patients live longer. Or, I mean, I don't know, probably you are, I mean, you're also as old. I mean, also when I started, I had these vulvectomies, these butterfly incisions, we used to call them, you know, where a small tumor in the vulva, we used to remove the whole vulva going to the groins, and we thought this is what makes the patients live longer. Absolutely not. So the concept of de-escalation is something that we have experienced since years and continue to do that. This doesn't mean that this is indicated in all cancers. On the contrary, for those special patients where de-escalation is not applying, but we need increased radicality, then we will have more time and expertise and money and beds to do it, because we won't do it for those patients where it's not necessary.
Yeah, I agree. And, you know, certainly it's a matter of just making sure that we have the appropriate data to drive our patterns of practice. And you know, this is also a practice changing principle with regards to no radical hysterectomy for the appropriate patients. And I think, you know, one of the things that I want to emphasize about that principle, and also outline in this article, is that, you know, certainly it shouldn't be assumed that the only criteria is tumor size. So many are now suggesting, well, anything below 2 centimeters should have a simple hysterectomy with cervical cancer. It should be still following the inclusion criteria of the SHAPE trial. So obviously less than 2 centimeters and patients with less than 10 millimeters of invasion, less than 50% invasion by the MRI imaging, and making sure that the patient fits those criteria before de-escalating as well on that on the management of patients with early cervix cancer.
And of course, we can extrapolate. So sorry, also for the value of trachelectomies. I mean, why is it not important? Why does it have no value to remove the parametria in a non-fertility sparing approach, but it does have a value to remove the parametria in a fertility sparing approach?
But
So
yeah, I mean,
so practically trachelectomies are not really needed, no? I mean,
yeah, exactly. And I think that now we're going to see, exactly. Exactly. I suspect that we're going to see a definite decrease in the number of patients having radical trachelectomies now. There's a question from the audience, and this is Arthur. So Arthur, I'll let you ask the question.
Hi, Dr. Fotopoulou. I'm asking if what are your opinions regarding the phthalocyanine, that is OTL-38 in ovarian cancer surgery? What is your opinions on using this technique in ovarian cancer surgery?
And Arthur, if you could just highlight, like, what is that? So that for the members of the audience who are saying, what is phthalocyanine OT38? So can you just clarify that?
I think it's an immunofluorescence technique that lightens up the tumor cells during ovarian cancer surgery. Yeah.
There you go.
Very good. So Oli Zivanovic is not here. So I will give his answer to that so that we represent him a bit. I will say, I don't really need to see more in ovarian cancer. I see enough. So again, coming back to what I said before with the PET-CT and carcinosis, all value for ovarian cancer surgery is to remove any macroscopic disease. You would never do a complete colectomy, a complete removal of the entire small bowel just because, for example, it lightens up, would you? You wouldn't do it. You would only remove what you see and what would be easy. You would never do that. And we know, and where is the value in removing microscopic disease? When for sure the patient will have disease in the chest, in the lymph nodes, in wherever. And why increase morbidity? Again, to chase ghosts. So there is no evidence that by removing non-visible disease in ovarian cancer, you increase survival. And no one would be mad enough to do, for example, a complete gastrectomy or a complete small bowel resection because it lightens up. So you, per definition, only remove what lightens up. That is easy. So what is the value of that? It's completely arbitrary. You like the answer, huh?
And for those of you who are further interested in this topic, please go to the special issue and read the article. Now, Christina, there was another interesting article that I was saying, when I saw the title, I was like, oh my God, what is this about? And it's about physical and psychological impact of surgery on the surgeon. What is that about?
That is a very important topic. That is very important. Sorry, now I will go very personal, but I've started Pilates lessons since 2 years because I had terrible back pain from the large debulkings because I like upfront surgery. So I was so close to just start indicating neoadjuvant chemotherapy so I don't have back pain anymore. So especially for the laparoscopic surgeons, and especially, for example, I have here in the UK my very nice colleague Alan Farding, who's like 2 meters, and when he laparoscopes, he laparoscopes with his long arms as if it's a walk in the park. And then I have my trainee who is like, I don't know, 1.5 meters shorter, and they can't even reach. So she has much more back pain and shoulder pain. I was talking to Gwen Ferron the other day, who actually had to have a shoulder surgery because of the laparoscopy and this movement, and all depends on how tall you are and how. So all these things are taking a strain on you, and nobody actually pays attention to that. So there is an increasing more emphasis on that, and Esther Moss from the UK has done even a lot of work in that. Of how even the posture, everything, kyphosis. You can almost always recognize a surgeon just by the way he or she stands. There is always almost a kyphosis. So these are things that we have neglected for years, just because we all are very concentrating on our patients, and we should. But we now all live longer, operate longer, go into pension less. Less young than we used to, so we need to stay fit, and that is why we chose to have a dedicated article just for this.
Yes. Well, no, thank you so much, and it was quite interesting. And as you were saying this, I was kind of fixing my own posture and sitting up straighter on the chair. So we have a couple questions from our fellows. First, Diletta Fumagalli. Diletta, you want to ask your question?
Yeah, thank you so much. So regarding minimally invasive surgery in ovarian cancer, what is your opinion on its use in interval debulking settings, and how do we select patients that can really benefit from a minimally invasive approach? Thank you so much.
So in order to have a minimally invasive approach, you need to be so in interval debulking, the importance of complete resection is even more than in primary debulking. In primary debulking, we know that even leaving less than a centimeter residual disease, the patients will benefit than more. But in interval debulking, it's either all or nothing. So you really need to get them tumor-free. So you really need to be certain that when you operate, you will strip the diaphragm, Morrison's pouch, everything that has even low residual or even small carcinosis. So to be able to do all that laparoscopically is tricky, needs effort, and needs also skills. My worry is always that in patients who will have a minimally invasive surgery, they will at interval, they will have a TLH, BSO, and omentum, and then the tumor behind the stomach, behind the kidney, behind the liver won't be seen just because it's not accessible. So will be missed. Yeah. For those 4 or 5% of patients who have a pathologic complete response and that really need only a TLH and nothing else, I mean, don't know, then we can really push it even more and say, do they really need to be operated? What is the evidence of removing that? But Anna Fagotti is doing a very nice study, and also with Pedro, of selecting patients for interval debulking surgery, minimally invasive. So that is something that will come. It needs skills, it needs expertise. I think if we push it even more, we need to define which patient even doesn't need surgery, if they have responded so well that you actually only do a laparoscopic hysterectomy and you're done. I always have a bit of, and I mean, we saw that in the LAC study, Pedro. I have always, I know it sounds really very old-fashioned now, but I'm always a bit concerned about the effects of CO2 on peritoneal carcinosis. And I mean, we saw that in the LAC, no? I mean, we saw that patients in the minimal invasive arm, they had peritoneal disease relapse, yeah? So there is definitely some effect of CO2 on this little peritoneal cells swimming and flying around.
Well,
So I think we need to prove safety first. We need to prove safety first.
well, thank you. And thank you, Dileta, for that question. And the answer is put them on the LANCE trial.
Exactly. Exactly.
So for those of you who may not be familiar with the LANCE trial, is basically comparing open versus minimally invasive surgery at the time of interval saddle reduction in patients who have had either a complete or near complete response. So more to come on that trial. We'll go to Ilaria Capasso.
Thank you for the great discussion. So my question is, given the sub-analysis showing better survival of primary debulking versus interval debulking in SOLO-1, does that mean that all BRCA patients should receive primary debulking regardless of possibility of complete gross resection?
So that's a very good question. It wasn't randomized for primary versus interval. Of course, patients who are operated up front without residual disease will do better because the easiest and best patients were chosen to be operated up front. So it's not a randomized design. So we can't say that, no. What we can say is from all the studies, from SOLO, from the Paola study, is that the magnitude of effect derived from the PARP inhibitors is highest, the less tumor burden you have. Yes, we can say that. But we can't say that the SOLO study showed that primary debulking is better than interval. Absolutely not. I mean, we saw that even in the ICON-8 data. Go to the ICON-8. The ICON-8 data, if you see the primary debulking arm, it's like that, and here is the interval debulking. Still, it's not because one is better than the other, it's because the best patients were in the primary debulking arm. Give us a few months, and we will answer this. Give us a few months.
Excellent. So I will actually take the question on the de-escalation of cervical cancer from Beatriz. She asked, would simple hysterectomy be suitable for patients without a prior conization, given that 80% of the patients had a prior cone in shape? We had just a recent discussion about this in a presentation that we did together with Marie Plant. And again, a conization is not a therapeutic procedure. A conization is a diagnostic procedure. So therefore, there should not be a principle of considering to having to do a conization for a better outcome in those patients. The data that shows that conization patients do better than those that don't have a conization is usually because conization patients are a lower risk profile than the patients who don't have a conization. So in other words, you have a biopsy that says cancer, you want to know if there is disease, microscopic disease usually, then you do a cone to see the depth of invasion. A patient who has a 3.5 centimeter tumor, that patient's not having a cone. So of course that patient is going to do worse than the patient that did have a cone. So again, the study was not about who has a cone and who doesn't have a cone. And the outcomes of that is that by nature, in order to determine the depth of invasion in these low risk patients, the patients did have a cone. So then therefore a simple hysterectomy was non-inferior to a radical hysterectomy. Beatriz, I hope that answers your question. I know it's a long answer, but certainly if you have any further questions, please let us know.
Yes, thank you. That answered my question.
Okay.
I mean, it's the same. It's the same with the previous question with the solo. No, the primary debulking patients did better because they were the best patients. Of course, the cone and also in all the. Sorry to say that now, but in the minimally invasive IDS patients, the non-randomized MIS IDS patients, of course, they are better than the open patients because only the patients with low tumor burden would go into the minimal invasive. And if you compare them with the open where you need whatever, of course they will do. So everything is a self-fulfilling prophecy of the retrospective data. So
very well. So Christina, I know that you have done a fantastic job as always without your other guest editors. And we don't want to obviously take too much of your time, but there is an additional question from Caroline. Caroline, do you want to ask the question yourself? So
Hi, good evening all. It's a very wonderful discussion. I'm Carolyn Gynecology trainee from India. So the question is, we recently had a patient who diagnosed high-grade serous carcinoma of the ovary, and pre-chemo she had an infiltrated growth in the sigmoid colon by sigmoidoscopy guided biopsy. It was proven as high-grade serous carcinoma. We went ahead with NACT. After 3 cycles of NACT, she had a complete resolution of the growth in the colon, sigmoid colon. So when we had posted her for an interval debulking surgery, we were at the aim like she will have she will definitely have loss of fat plane with the sigmoid colon, and she will definitely require an LAR is what we thought of. But to our surprise, when we opened her, which was very clean pelvis, like with there was no the planes between the uterus and the pouch of Douglas, everything was very clean. So we didn't do an LAR for her. We just came out, but we had a doubt whether should we have undergo like collectively would have done a LAR or not.
no, my answer, and I think that also Pedro agrees, is absolutely no. You only remove what has tumor. And coming back to before, okay, to do a rectal resection is easy. So what would you do if the whole small bowel had previous, in these patients with extensive carcinosis where you give neoadjuvant and then everything melts away? What do you do? Do you do an elective complete small bowel resection or a stripping of all the mediastinal lymph nodes? Of course not. Why would you do it in the rectum? Absolutely not.
Yes, I completely agree. Completely agree with that principle. So, Christina, again, as always, thank you so much. You have done a fantastic job on your own as the sole guest
not on my
editor.
own, with you.
And then, and thank you again for obviously not only just your contributions to gynecologic oncology, but to being a great role model. We have so many women, gynecologic oncology fellows, trainees, and I really want to recognize that you really stand out and continue to do so and inspire others to do as you have. Thank you.
My pleasure, and the inspiration is mutual. I couldn't do any of this without you all, so I have to thank you.
Thank you all for joining, and we look forward to the next Journal Club. And we're really, again, also very excited about the 2025 special issue, which has already started. So thank you all once again.
Thank you all. Bye. Bye. Bye.